It's my very great pleasure to welcome you to this webinar, Prediction in Practice, which we hope will be a practical guide to applying the new Australian Cardiovascular Disease Risk Calculator. I'm Garry Jennings, and I'd like to start by acknowledging the traditional owners and custodians of the country throughout Australia and indeed beyond, and their continuing connection to land, waters and community. We pay our respects to them and their cultures and elders past, present and future. We have over 2,000 registrants this evening, so many of you from Australia, but many also from around the world, and welcome to you all. I'd like to introduce you to our wonderful array of panellists tonight. We have Dr. Garry Deed, who's a general practitioner and chair of the Diabetes Specific Interest Network of the Royal Australian College of General Practitioners. Professor Anthony Russell, who's a diabetologist and president of the Australian Diabetes Society and director of endocrinology and diabetes at the Alfred Hospital in Melbourne. And Professor Jenny Doust, who's also a general practitioner, but she's a clinical professorial research fellow in the Australian Women and Girls Health Research Centre at the University of Queensland. And all of my colleagues on the panel tonight were members of the various risk expert subgroups that contributed to the development of this wonderful new risk prediction tool. I'm going to begin by asking sorry. I've just lost yes, I'm going to begin by giving you a very brief overview of the calculator. It was presented as a whole webinar about a month or so ago, and you can see there the link to that program on YouTube if you'd like to revisit it. It's called the Australian Guideline and Calculator for Assessing and Managing Cardiovascular Risk. Next slide, please. And that's that slide you just showed was what you'll see when you go to that website. It's the first time these have been updated since 2012. It's been specifically modified and recalibrated for the Australian population. And it was a huge exercise. It brought together members of the Australian Chronic Disease Prevention Alliance, which is not only the Heart Foundation, which led the project, but also Diabetes Australia, the Stroke Foundation and the Australian Kidney Foundation. It involved expertise from 9 advisory groups, very multidisciplinary, 10 clinical specialties were represented, and over 20,000 health professionals and almost 200 stakeholder groups, as well as many consumers were invited, and many did give feedback. This risk prediction guideline is applicable to over 8 million Australians, so it's something that we hope and expect will get very wide use, and indeed since it's been launched we've been amazed by the uptake. It'll provide a more accurate prediction of cardiovascular disease risk, and hopefully that will lead to more lives saved from heart attacks, strokes, cardiovascular events. Next slide. I talked about the extensive collaboration and the size of the activity, and you can see in the green here, the blue-green here, the various expert groups that contributed to it, with all of the multidisciplinary expertise that I've talked about. There was an overlay throughout of consumer feedback and input, very powerful input from consumers, and also from First Nations, where we had a special expert advisory committee which really looked at everything that was recommended, all of the text, and provided an Indigenous perspective where that was relevant. Next slide, please. It embedded within the guideline, and the guideline is very comprehensive. It takes you from go to woe as far as assessing risk in primary prevention, was the calculator, and the calculator originated from the New Zealand Predict primary care risk equation. That was derived from over 250,000 people in New Zealand. It was checked against and compared with all of the other risk prediction equations that are available internationally, and on a very formal criteria-based assessment came out the most suitable for our purpose. It had to be modified for the Australian population. The New Zealand population is very similar to Australia, but there are some differences, and it needed to be recalibrated because the rates of cardiovascular disease are a little different in the two countries. And all that should add up to a much more accurate risk assessment. Next slide, please. What's new in this? It's a broader range of ages. We'll go into those in a little bit, but it applies to more people than the previous assessment. I talked about the new calculator. There are new risk categories. They are different to the previous risk categories in the old Framingham-based equation, and we can talk about those a little bit later too. And we know that the variables in these equations don't account for everything that the health professionals know about the person in front of them, and we've allowed for the application of what we're calling reclassification factors, and that'll be the subject of quite a lot of our discussion tonight, to redefine what calculation you get from the calculator itself based on health professionals' knowledge, expertise, and what else they know about their patient. There's been a great emphasis on communicating risk in a way that's appropriate to consumers, and I've already talked about the overlay as far as First Nations people input was concerned. There are a number of new things that are brought into play in the guideline, of which pregnancy complications is only one. There are things like socioeconomic factors, mental health, a range of other things, and I think we'll be talking about them in some of the case stories that follow. Next slide, please. So what does this mean for those of you in primary care? It means targeting your heart disease screening to the right parts of the population, that is those who benefit most from it, accurately predicting risk, and therefore making sure that those that get pharmacotherapy are those that are going to likely benefit the most. A more comprehensive risk assessment, and a facilitation of shared decision making to make sure that we get patient engagement. Often when we're trying to tell people with no symptoms at all that they might need lifetime management and even pharmacotherapy. And it supports the best practice management of cardiovascular risk. Hopefully that will provide better outcomes too. This is straight from the website. If you are using this calculator, many of you will have seen it. And it's a 5-step process. Now, the first step is identifying the right people, everyone between the age of 45 and 79, a little bit younger if they've diabetes, starting at 35, and for First Nations people, 30 to 79 years, although it's recommended that First Nations people have their risk factors assessed from the age of 18. Secondly, you apply the calculator, and it's got new variables you can see on the list there, as well as the standard old variables that like age, sex, blood pressure, cholesterol, etc. And the new feature is a special sub equation, which is optional, but for use in people with diabetes. We've generally assumed in the past that everybody with diabetes is at high risk, but we know from the New Zealand experience that there's a spectrum, and this allows you to more accurately define the risk in those people with type 2 diabetes. You, out of that, identify a CVD risk category, which might be high if it's greater than 10%. As I said, that's different to the previous level. Intermediate between 5 and 10%, and low if it's less than 5%. 5-year risk of a major cardiovascular event. Then you're able to apply these reclassification factors, things like ethnicity, coronary artery calcium score if you have it, family history, measures of renal function or severe mental illness. Then the fourth step, the important one, is turning the screen around to the patient and communicating that risk and discussing what it means and what could be done about it. And finally, of course, managing the risk whenever that's necessary, including the obvious lifestyle factors and pharmacotherapy. Next slide, please. So I'm going to hand over now to Dr. Garry D, and he's going to give a live demonstration of the calculator. He's going to highlight those new variables and explain the new categories, as well as giving us some information on some of the support tools that are available. So thank you very much, Garry.
Thanks, Gary, and thanks to the Heart Foundation for inviting me. And also welcome to everyone online. And I know that there's a whole series of primary care practitioners and practice nurses out there. So welcome, and let's go through this in a practical way. I've just started to show you like Gary showed you, this is the website here, cvdcheck.org.au. It's the same website as was used before, and you can have that. I know that's linked onto my software that I use in clinical practice. I use Best Practice, but if not, you can use that running in appropriate software on your desktop. And it starts with this, the summary that Gary went through, the 5-step process. I really ask you as a general practitioners, maybe and practice nurses, have a little bit of a practice before. If you're not familiar with it, just go into it and have a look at some of these little features and get yourself comfortable with it, because it's the actual depth of information that you put in, but also the depth of information you get out of it that allows you to develop more precise ability to support your patients. And I'll go through some examples of this in a moment, but I know Gary went through this, but I'll just reinforce again that step 1, it's important to understand that now we're identifying people with cardiovascular risk. We're looking for people at risk, and it's applied for most people between the ages of 45 to 79. So it's been extended now up to the age of 79 compared to the previous calculator. I do want to remind you that there's also earlier risk assessment applied to people with diabetes. So that with people with diabetes, it goes down to the age of 35. First Nations people, we're taking the risk down to the age of 30. So understand that there's a little bit of modification about identifying people there with risk. Down to step number 2, which is use the calculator to assess cardiovascular risk. I'm actually going to go through that with you in some practical demonstrations in a moment, and to go through some of that detail. After that, we're going to show you how it identifies cardiovascular risk. As Gary mentioned, there's a little bit of a change around some of the classification of percentages there, and the communication of cardiovascular risk, as Gary said, is so important. In general practice, in any clinical practice, numbers mean something to yourself, but to patients, we need to have tools that allow us to make that meaningful to them. And in this whole process, as I've been sitting and watching how the Heart Foundation has really applied themselves and given you some really good tools here, visual tools that you can print out, use for your patients. Not only that, then it goes to number 5, which managing cardiovascular risk, including lifestyle factors, pharmacotherapy. There's some resources there. So very exciting tool. But if this is actually live as we speak, so we can hopefully start the calculator. So when you click on that button on the website, it comes up here as a blank page, and it just puts a lot of those 5 boxes into a hierarchical sense. It mentions that, it's recommended for those patients, as I said, for assessment without known atherosclerotic disease. It's important to understand where it's placed. People with existing atherosclerotic disease should apply clinical evidence-based guidelines to them. However, it's also then determined that there are clinically determined high-risk categories where maybe you should think about not having actually necessarily using this tool because they're already at high risk. And that's moderately to severe chronic kidney disease. And actually that helps you define. Just go over the question there as a hover, and it comes up with that information defining people with moderate to severe chronic kidney disease. Of course, patients with familial hypercholesterolemia are also automatically considered high risk. And if you tick that box, you'll see that it goes out, say, for instance, it'll say, proceed to a high-risk management page. So I'll click out of that now, but that will automatically help you, and wonderful communication tools. Age is important for the patients. We know this coming from the Predict tool, as I said, up to the age of 79. And very importantly, sex at birth, smoking status. I don't think anyone finds it controversial. The previous calculator included things like the systolic blood pressure and also cholesterol values. Interesting here, it says the ratio of total cholesterol to HDL, but if you don't have that clearly obvious to you, you can click down and enter total cholesterol and HDL as per the previous calculator. I'll show you how we do this in a moment. Importantly, what is new is the use of cardiovascular medicines in the last 6 months. And when you click on those particular categories, it will alter, for instance, some of the risk calculation that will occur when you push calculate at the end. Antithrombotic medications, again, what a wonderful tool. It allows you to define what these are by hovering over that question mark there. So I think you got a understanding of that. What's new also is history of atrial fibrillation. This is optional, but you can put that in for a patient as required as well. What's very different, and what's really, we've got a lot of feedback from many people around this, and when we were developing the tool, this is very important, was around postcode. And people say, why do you need postcode as part of cardiovascular risk? And I think as a collective group, the Heart Foundation, I say we, but the Heart Foundation really went into the detail about population level variables that may affect cardiovascular risk, because we've all known that social determinants of health are often determining cardiovascular risk. And so by putting in your postcode, there's an adjustment that occurs that may have an impact on the cardiovascular risk because of how and where people live. Of course, diabetes was mentioned, and we're going to go through a diabetes case study, and those variables will be expanded. But let's go through a typical one that I might do in my clinical practice. So I've just flicked to a pre-populated one, so just to save you some time. So I said this patient who is female is not of clinically determined high risk. I said, remember those chronic kidney disease, those call-out boxes are there. The age is 62, and you enter the patient's individual age. I made this a female, but also put in currently smokes. Systolic blood pressure is 142. Total cholesterol was 5.8, and I put in HDL 0.98 directly from the clinical record. It can't be easily pre-populated at the present time, but it's not very hard for you to do. It only takes, by this time, you only go into less than half a minute. Remember the new about use of cardiovascular medicines for the last 6 months, and as defined by each of those call-out boxes, but this lady was on none. No history of atrial fibrillation, but she lives in the postcode of 3175. And see how it came out with a CIFA quintile of category 1, which is considered the most disadvantaged. I could change that and put in my postcode here in my current suburb, and it will come up as a 5. We're in probably the least disadvantaged population. But if we just put in 3175, and that she didn't have diabetes, done that, I find that in clinical practice not too difficult to do. I'm able to do that fairly swiftly from both my clinical records and talking to the patient. Often do it with the patient sitting in front of the chair saying, look, let's turn this number into something meaningful. So let's push the calculator button. So that woman, remember, she was a smoker, 62, marginal blood pressure. Her risk is intermediate. Remember, the cardiovascular risk tool now has classifications between less than 5 to 10%, and over 10%, and then 15% or high. And of course, over 10% is going up to a higher risk as well. So, and interesting, this then shows you the reclassification criteria that may be applied to this person. And very importantly, down classifying risk is if they've had a coronary calcium score of 0. And we know that the predictive coronary artery calcium score of 0 probably lowers the risk of potential cardiovascular disease, atherogenic cardiovascular disease, within the next 5 years. East Asian ethnicity also has been shown to possibly recalculate down risk. So you could apply that and say, look, you're 9%, but maybe your risk is a little bit lower. It's usually used for people on marginal risk. So I'm really interested in probably not down classifying, because I don't think those factors would get her less than 5%, but it's really, does she go into the high classification? By those up classification risks is that if she's got a high coronary calcium score, is she of First Nations? Is she of Maori or Pacific Islander extraction? Is there a family history of premature cardiovascular disease? That was something that was not applied in the previous calculator from 2012, and I think that's a really important aspect if we push that there. Chronic kidney disease again comes up. It's not necessarily the moderate to severe as before, and also people living with severe mental illness. And we know that there are aspects of severe classifiable mental illnesses which are defined by people who are requiring specialist treatment probably either received specialist treatment or not in the last 5 years. And then you can proceed to either reclassify or not, but let's take that out and I'll just continue without reclassifying. And it comes with this wonderful tool, which actually allows you then to sit with the patient, show them, what does that risk mean? It means that 9% risk that 9 patients out of 100, if you're one of those people, might have a heart attack or a stroke in the next 5 years if you don't take action. So it's not a threat, it's about, this is an opportunity to make a change. And you can then print that information for the patient. Remember, she was a smoker, and then if we say quit smoking, look, it shows you that you can decrease the risk. And you see how wonderful that is by showing the person, if you stop smoking, your risk goes down to almost the lower end of that intermediate risk and into the low risk. And you can also do it by lowering blood pressure. If you lower the blood pressure, there's a decreased risk by 2%. And certainly, again, lowering LDL in this person may not make a difference, but certainly the biggest difference is quit smoking. Remember, and then lower down, you've got all these resources. You can click on these things and they are patient-based, evidence-based resources. And you can print these results quite quickly for patients. And here are some of the resources. I hope I'm not going too fast. Healthy eating guides, smoking cessation, very, very general practice based. How to incorporate physical activity and guidelines for those sort of things. I can actually show you some. So smoking in the Heart Foundation has some of those resources, and it goes out to those resources automatically, and you can then help provide those in a printable form for your patient. All right, so let's go back to another patient. I'll see if I've got another patient for you. Now, I've got the same female patient, but I said never smoked. And we showed you how reclassified, the classification of risk is lower, but let's just show you when I put that in again. I have to put in that she's female. So it's a no-brainer. You have to fill in all the necessary classification categories, and it's 4% risk. So I just showed you, and also that. But if we put in that she's got a family history of premature disease and chronic kidney disease, what about if we reclassify to higher risk here? And you might say to her, look, that increases your risk to high risk, for instance, by those 2 classifications. And again, it puts that high risk algorithm there, or the demonstration, and you can print that information for the patient quite quickly. Again, I'd want to emphasize again, those resources are available to you, that how to lower your risk, how to print those results, and also those other resources, as I mentioned. One last one, I don't want to take too much more time. I put this next one in. Let's make him male. Previously smoked, same age, but now that we put in, and this is a segue into the next presentation, that they've got diabetes. And I won't go into all of these because my colleague Anthony Russell will go through these. But when you click on diabetes, say if it says no, but if you click on yes, it presents this box. I haven't filled this in, but which we'll show you in a moment in a very clear clinical case about putting in important variables that affect people, particularly with diabetes. And I was really happy with the Heart Foundation because of my passion and interest in managing diabetes, that this was expanded within this current guideline. All right, so in summary, you've got this new cardiovascular risk calculator that's a wonderful tool that allows you on your desktop, working with your patients, to accurately assess them on an individual basis and provide them with a clear and precise classification of risk. Remember, low risk now is less than 5% risk over 5 years. Intermediate risk is between 5 to 10% risk over 5 years. High risk is over 10% risk. And those reclassified risk categories were redefined in this to help you assist your patients. And remember, the guidelines provide that effective communication tool, and don't forget about the resources to support management. So I'll go over and pass over to Garry again. Thank you, Garry.
On mute, Garry.
Yeah, thank you very much, Garry, for that. That was a wonderful and clear demonstration of how it all works, and I think I could probably do it myself now. So I'm very grateful. We're going to, as you foreshadowed, move on to a second case, and Professor Anthony Russell is going to present that, and he's going to show us how the diabetes-specific equation works, and I think you'll find that also a very useful and clear part of the story. Thank you, Tony.
Great, thanks, Garry, and hopefully I'm sharing my screen there. This is a particularly relevant case, given it was World Diabetes Day yesterday, if I can put out a plug for that. And also there was a launch by James Fate for the Pledge Against Diabetes Stigma, and I think that's very relevant as well. So this is the beauty of the new risk calculator, is that there's a specific part of it that addresses people at high risk with type 2 diabetes in particular. So we're going to go through a case relevant to this to demonstrate how that can be applied. So this case is Helen. She's a 59-year-old, works as a midwife and does shift work. And she's come to you as her general practitioner for review of her diabetes care plan. She is an ex-smoker, having smoked quit smoking more than a few years ago. And by definition with the calculator, less than 1 year, you're a current smoker. So if it's more than a year, you're an ex-smoker. And she drinks alcohol occasionally and often finds herself eating fast foods and takeaway meals, which sometimes happens with shift work and that lifestyle. She does manage to play tennis once a week, but otherwise little activity. And she has a past history of type 2 diabetes, and this was diagnosed 8 years ago. She is currently not on any medication for her diabetes, no insulin or any other medications. There is a family history of heart disease, with her mother suffering a heart attack at the age of 73 years of age. And socially, she lives with her husband, 2 teenage children in Sunnybank, and obviously we've just heard the relevance of that when we're looking at the cardiovascular calculator. We're needing to know a postcode. Now, you have some information in terms of clinical observations. We've got a blood pressure, 142 on 80 millimeters of mercury. We have a recent cholesterol of 6.4 with an HDL of 1. And the glycemic control with an HbA1c of 7.7%. As part of the annual cycle of care and screening for kidney disease, a urinary albumin-creatinine ratio has been performed, and that's 2 milligrams per millimole. And of course, along with that, we've got an estimated glomerular filtration rate, and here it's at 86 mils per minute. And Helen has a weight of 80.5 kilos with a height of 1.7 meters. And if I recall, I think that gives a BMI of about 28 or so. So we would hope, as part of the assessment of Helen, she's got a few things going on as part of her review that you might consider optimizing her management of her diabetes and considering not just being glucocentric, but considering her overall cardiovascular risk. And that this would be a very relevant case to go and apply the equation. And it's really beneficial here that we have the ability to delve further into the risk of someone with type 2 diabetes. This is a difference compared with the previous calculator, where age over 65 with diabetes immediately puts you into a high risk category. But we know from the data from New Zealand and so on that there is a spectrum of risk in people with type 2 diabetes. You could have newly diagnosed of short duration without any complications, and that person is a much different risk of developing cardiovascular disease compared with a person with type 2 diabetes, much longer duration, and, for example, with elevated albumin-creatinine ratio. And we'll go into the applicability of that. So with Helen, we therefore know that she doesn't meet the criteria immediately for high risk. She doesn't have moderate to severe chronic kidney disease or familial hypercholesterolemia. So we'll continue to apply the calculator. So she's 59. She's obviously female. Because she's ceased smoking more than a year ago, she's previously smoked, and we had her blood pressure recorded as 142 millimeters of mercury systolic. We know her cholesterol was 6.4 with an HDL of 1, and she isn't on any medications currently. She has no history of atrial fibrillation, and remember, she is from Sunnybank in Queensland with that postcode of 4109. And calculating this CFA quantile, which puts her in the mid-range of disadvantage or advantage. And here we have the diabetes equation to delve further into her absolute risk. Now, importantly, this is based on the predict equation from New Zealand of a cohort that included people with type 2 diabetes. So we don't have the data specifically on type 1, and that may be a question to address at the end of this. So when we go into the diabetes, we can provide the additional diabetes details. So remember, Helen had a duration of diabetes since diagnosis of 8 years, and HbA1c of 7.7. The urinary albumin-creatinine ratio was not elevated at 2, and her renal function is quite good with an eGFR of 86. And we can calculate her BMI by putting in the weight and height in meters. And she is not on insulin. You know, insulin is in there, not to say that insulin specifically, because it will, if you tick that, come up with a higher risk, but it is just a marker of severity of disease, and we have to importantly understand that that does not increase the risk of cardiovascular disease by being on insulin, but in the equation, it is most likely a marker of severity of the diabetes that you have. And then it can calculate the risk by plugging in these variables for Helen. So with that, it's come out to an intermediate risk of 6% risk of having an event in the next 5 years. And the next step, as Garry pointed out, was, are there any reclassifying characteristics or groups that you'd like to consider? We know she's of a Caucasian ethnicity, and so that's of no issue. We don't have a coronary artery calcium score. There was a history of cardiovascular disease with her mother, I think at the age of 78. But if you were to hover over the question mark and the definition of what a premature family history of premature cardiovascular disease is, that would be a first degree relative, if female under the age of 65 or male under the age of 55 having a coronary event. And so for Helen, the mother's age of having that event was at the age of 70 odd, and so we would not tick that box as a to reclassify this risk. So we could proceed in Helen and continue without reclassifying, because there's nothing that we're particularly concerned about. And then the calculator will come up with this risk. So we've got a 6% intermediate risk. And as Garry alluded to, a lot of effort has gone into helping you in that consultation convey this risk with the patient in front of you. And here it's demonstrated with 6 in 100 is that risk. So then we've got this intermediate risk, and we've got to work out, well, what are we going to do about that, and have that discussion with Helen. Now, the recommendations would obviously be to address lifestyle issues, and there are a few things here in Helen's history that you could then consider addressing and looking at resources to consider that. We heard that she doesn't do regular exercise, and perhaps her nutrition isn't fantastic with quite a bit of takeaway food. And that would be something to consider addressing. And I know in the resources that you could go into, there might be recommendations around DASH diet or Mediterranean diet that are supported by evidence in terms of addressing lifestyle measures here. And then we've got these variables in terms of blood pressure and cholesterol. And in this intermediate category, the recommendation is to consider prescribing blood pressure lowering and lipid lowering medications in this intermediate risk. And this would be a discussion that we should be then having with the person sitting in front of us about the benefits and risk, and discussion about whether that would be a good idea to consider in this patient. So it's very relevant, I think, this calculator to help us have that discussion and really display it graphically and lead to a good discussion, interaction, and with the patient to address this cardiovascular risk in this person. So that's the case, Garry. So thank you.
Thank you very much, Tony. Once again, a wonderfully clear description and you know, a really important new feature in the guideline. We're getting some terrific questions coming through on the Q&A box. Please, we might not get around to all of them, but please feel free to enter your questions. And we're having quite a long discussion section at the end, and we'll deal with as many of those as we can. We're going to move on to a different case study now, and Jenny Doust is going to present that. And it's going to bring in that somewhat, sometimes quite vexed issue of coronary artery calcium scoring. So thank you very much, Jenny.
Thanks, Gary. And I'm sure, like many others on this call, we've been talking about absolute risk for like decades now. And I'm hoping that the new guidelines will hopefully make things clearer. They've tried to bring in best practice communication risk tools. So hopefully this will make GPs' jobs easier. I've been watching a couple of the questions in the chat. So there's a couple of those that I'll address as we actually go through, I think. All right, so my case study is about Raj. Raj is a 55-year-old lawyer who works long hours. He smokes 10 cigarettes a day. His father had an MI at 50 and his mother is diabetic. He works late, has a whiskey as a nightcap, and often has a few beers and some whiskey on the weekend. Mostly he eats takeaway as he doesn't cook and he doesn't have time to exercise regularly. His ethnicity is Indian. His medical history is that he had depression and was treated with Zoloft for 2 years, but that was discontinued a year ago and he's been well since. No history of CVD or diabetes. He's not on any current medications. His social history, he's divorced and both adult children are at university and he lives alone in an apartment in Parramatta. So you have the following clinical and laboratory measures: blood pressure 130/85, total cholesterol 6.0, HDL 0.8. So that gives you a ratio of about 7.5. LDL is 4.0, fasting glucose 5.5, EGFR greater than 90, and his weight is 89 kilos and height 175. So that gives you a BMI of 29. Next. So if we enter all of those things into the calculator, so I think we've seen this a few times now, how we do this, and his C for quintile is comes up with 3. So just to talk a little bit about that C for quintile thing, because obviously that's something quite new and people are kind of obviously querying, why do we want to put postcode into the calculator? So the whole point of these calculators is to try and estimate the risk as well as we can. When you think about how these calculators are made and developed, the predict calculator is based on general practice record data. So that the best measure of socioeconomic demographics that you have from the general practice record that you can kind of get out the back end is the postcode. Now, that's obviously a fairly rough measure of what your true socioeconomic status is, but that's the best you can use in the construction of the calculator. What we would recommend is that, you know, if you think that this person, you know, you're living in a quintile that's actually a 1 quintile, but this person is actually a much higher socioeconomic status, you could adjust your risk down, or vice versa. If you're in a postcode that's a 5 quintile and this person is clearly socioeconomically disadvantaged, then you would increase the risk. So that's to try and explain. It actually makes quite a difference, and it's quite impressive how the socioeconomic determinants of health are now actually being included in calculators, whereas the previous calculator, we basically just didn't include it at all. All right, so now if we hit calculate, so, yeah. And then that Raj comes up with an estimated risk of 8%. So there's a few things about Raj that we want to consider in terms of reclassifying his risk. So next. Yeah, so the first one would be his ethnicity. So in the predict calculator that's used in New Zealand. It actually includes a measure of ethnicity, but that isn't exactly matching with what happens in the Australian population. And so what we've done is we've said that we know that if you have one of these ethnicities, that it's likely that the calculator will underestimate your risk. And conversely, if you have an East Asian ethnicity, then it's likely that it will overestimate your risk. Again, you have to have some kind of sense of judgment about this, because clearly people don't fit into neat categories of ethnicity. But if someone is, for example, a South Asian ethnicity, then you might want to reclassify their risk up. The next factor would be his family history of premature CVD. So his father had an MI at 50. It won't go to the neat little call-out box that we saw in the previous slides, but that is classified as a family history of premature CVD, because if you have a male first-degree relative who had a CVD event at an age less than 55, then that's considered relevant. Okay, next factor. Now, people living with, sorry, can we go back to, there we go. People living with severe mental illness. What the evidence from the New Zealand population was that if a person had accessed a specialist medical service in the past 5 years before the assessment, that they were at increased risk. Now, clearly there's a continuum from people who are quite severe mental illness to people who have no history of mental illness. Raj actually fits somewhere in the middle here. So again, there might be some increase of risk with that past history of depression, but the actual classification of people living with severe mental illness is that they've accessed specialist mental health services in the past 5 years. The way we've actually worded it is also, we've tried to make allowance for the fact that people could have a very severe mental illness, but they haven't actually accessed services for various reasons. So again, you have to use your clinical judgment here a little bit and think about whether that person might be slightly higher or lower than your estimated risk. And then finally, is whether they have a coronary artery calcium score greater than 99. Okay, so next. So what the guidelines say about the coronary artery calcium score is it's not recommended for population screening. If you calculate that someone's at a high risk with the calculator, then it's not recommended that you would do coronary artery calcium score testing, because it's not going to change your management. You should be treating that patient. If the person has known CVD, again, that patient should be on treatment, and so the coronary artery calcium score is not recommended. If you can hit next. This is where Raj fits. What the guidelines say, that CVD risk assessed as low or intermediate in a person with one or more additional risk factors. It could be considered if available and affordable, and then you would make decisions about treatment based on the coronary artery calcium score. And just to mention that when it talks about coronary artery calcium score, there's also the issue about how often should you do it, and in the guidelines what it says is to consider retesting in 2 to 5 years. Okay, next. So if you were to just hit that reclassify button, it would take you to a risk of 10%. Now, clearly it's not possible to give you an exact number how much to reclassify somebody. Again, you need to use your clinical judgment about how much this person is going to go up. One of the important things to think about with these risk categories, these high, intermediate and low, is these are not definitive boundaries. They're not definitive in the way a clinical diagnosis is considered a risk category. Definitely you want to think about if someone's a high risk, that they should be on blood pressure and lipid lowering medications. And as Tony said, in the 5 to 10% group that you'd want to consider prescribing. But there's certainly a clinical judgment should be used about whether you should be using statins and blood pressures. And it's not so definitive as, you should absolutely be treating someone who's got diabetes with a hemoglobin A1C, to get their hemoglobin A1C down lower. You do need to use your clinical judgment here. One of the things to think about is also in the previous guidelines, the threshold was 15%. And that 15% was based on the cost effectiveness of statins. And of course, statins have since come off patent, they're much cheaper. So again, the restrictions from the PBS about when you can use a statin have been removed. It's the PBS guidelines say that use it according to the absolute risk. So it's really clear that you want to use statins in someone that you consider is going to be at high risk of CVD. Next. So the CVD risk calculators are based on these epidemiological groups. They're not 100%, that's what I mean by, they're not absolutely definitive categories. They'll miss some people who go on to have a CVD event. And you also will be treating a lot of people who don't have a CVD event. And it's impossible to tell at an individual level who might and who might not have had a CVD event. We did an analysis looking at the Framingham risk score calculator and looked at men aged 35 to 75 followed for 10 years. This was when the threshold was at 15%. So 30% of people who had a CVD event were classified as low risk by the calculator. And on the other hand, 78% of the men classified as high risk by the calculator did not have a CVD event after 10 years. So this is about this trade-off between the sensitivity and the specificity. Next. So one way of kind of showing that overall accuracy of how well the risk calculator predicts who does and who doesn't have an event is the C statistic. That varies from between 0.69 or 69% to 0.8 or 80%. The previous calculator had a C statistic of 0.76 in the Australian population. Probably with the new calculator, it's slightly better than that. Okay, next. So would coronary artery calcium score help? So the coronary artery calcium score, it's a measure of the calcium phosphate hydroxyapatite crystals that are deposited into the extracellular matrix. It's been known and been around for a long time. It was first described in 1995. Next. So as part of the new guidelines, there was a review conducted that looked at how much improvement you get if you add coronary artery calcium score to a CVD risk calculator. So there is a gain, but it is quite small. So if we say the C statistic is 0.76, it goes up by 0.03. So it'll go up to 0.79. On the flip side, the potential harms or things that you need to consider that are not beneficial about CACS is the cost incidental findings, and incidental findings could go both ways. They could be beneficial or harmful, but overall the studies haven't shown that incidental findings benefit people. There's a radiation exposure, although that's fairly small, and there's also a carbon footprint. And there's also the problem of potentially false reassurance. And this is where we go back to the kind of general practice principle of don't do a test if you don't know how it's going to change your management. Next. So my general practice brain would go, I need to kind of prioritize what I'm doing with Raj. My first priority by far would be trying to encourage him to stop smoking. Possibly my next actual priority would be to try and increase his exercise, because that's going to help both with his CVD risk and also potentially with depression and multiple other things. And then the next thing I would be thinking is potentially whether to put him on a statin. And then after that, like the guidelines actually say that if you consider someone high risk, you would put them on both a cholesterol and a blood pressure lowering drug. The current guidelines in Australia would say that that's not a level of hypertension that would be treated. But again, that would be something that you could consider, but I would put that down as a lower priority. Okay, so next. So what I would personally do with Raj is I would hit that reclassify button and put him up to that 10%, and then show him with these icon arrays how stopping smoking, etc., would help his cardiovascular risk, and do it in some kind of priority order. Okay, next. So the other thing to consider is that, and this is where I go back to what I said before, that 5% and 10% are fairly arbitrary boundaries. And if you actually ask patients whether when they want to take a statin to prevent cardiovascular disease, it varies quite a lot. So this was a review that we did where we looked at studies where they had asked people would they be willing to take a daily pill to prevent cardiovascular disease, and where it considered that there was no cost and there were no side effects from that pill. And people vary enormously about where they would consider that it's worthwhile to take a pill. And that gets reflected back to us in practice, where we start people on treatments or recommend treatments and then patients don't comply. So I would be very much trying to talk to Raj about what his priorities are, and talking to him about how can we reduce your cardiovascular disease risk, and which of these things are you going to put as your highest priorities to do that. Okay, next. Okay, so this is where we can all think about whether we would request a coronary artery calcium score for Raj. Certainly the guidelines recommend that you could do it. There's certainly people that are saying that we should do it. But, I think it's very much a thing that you need to discuss with your patients and think about how it's going to change your management. So you can all vote. So what would be interesting would be to know how that varies according to the postcodes of the people who responded to the questions, because I'm sure cost is a factor in this. So, yes.
Yeah, I think it's the right answer, Jenny. But okay. So Thank you very much, Jenny. Again, very clear. And I think the one theme coming through is that the calculation is the beginning of your assessment. Reclassification factors are all about your clinical judgment and what you know about the person in front of you. And the art, there's plenty of room here for the art of medicine and no absolutes. We've got a number of questions. I'm just going to deal with one that covers about half a dozen questions at once, and that's about familial hypercholesterolemia. That's a automatic high risk. That's a very specific diagnosis. That's not just someone with a bit of cholesterol in the family. That's someone who a Dutch lipid score has scored highly, and hopefully somebody's gone on to have genetic testing for that very serious condition of familial hypercholesterolemia. Just dealing with one of the other questions quickly, a practical one: should we use the current blood pressure even if it's treated with medicines? Yes, it should be the most recent blood pressure you have, preferably on the day. And another one I want to deal with before I go back to the panelists is, how does the use of cardiovascular medicines affect risk? And that takes us back to how these calculators are derived. They're derived from filling out a whole lot of information on a patient record and then seeing what events happen in the next 5 years. It is quite agnostic as to causation. It just looks at associations. It doesn't know anything about the pathophysiology or the causes of disease. It just knows that these things are independently associated with risk if it's to appear in the equation. And some things are not in the equation that you might be wondering why, and that's because either they're not independently associated with the risk, that is, they carry the risk, but they carry it through some of the things that are variables that are already in the equation. If we take cardiovascular medicines, if you want causation, just remember that people go on these for a reason, and that whilst their medicines themselves are beneficial, they don't necessarily bring risk down to that of a normal person who's never needed those drugs. So let's move on to some of the other questions and bring some of the other panelists in. I think we've partly dealt with this, but this is looking at it the other way. How would we classify CIFA in a high risk environment such as prisons, but in a good postcode? Or even worse, how would we manage it with someone that's homeless? I don't know who wants to deal with that. Jenny, that was part of yours.
Yeah, so this is where what I was talking about, that the way that the calculator is constructed, all the socio-demographic information that they have is the postcode, and that's a very rough measure of socio-demographic disadvantage or advantage. So if you think that that person doesn't really match the postcode that they're in, then you need to calibrate the risk up or down a little bit. We can't tell you exactly how much. What matters is, does that put the person into a different risk category? So the most likely situation, I guess, that you'd consider would be someone who's an intermediate risk, but they have, significant socioeconomic disadvantage. Then I'd be putting them up into the high risk category, especially someone who's, say, homeless and likely to have, mental illness that's often not even diagnosed or not being treated. So,
good, thank you. Weight or BMI are included in the calculation for the diabetes population, type 2 diabetes population, but not for not in the general calculator. Why would that be? Gary, do you want to speak to that?
I think it's around the evidence, as well as what Jenny has been sort of expanding, is that we can only put in things in the calculator that have clear links to clear evidence there. And the evidence in the diabetes population was clearer than the general population. But again, it's a risk calculator to allow you to apply clinical skills to your patient. I mean, people have asked these questions about people who are, I'm diverging a little bit, Leonard, that say they're First Nation with only half First Nations people. You know, use your clinical skills to actually classify according to the individual in front of you. And same as with weight and severe obesity, carries other cardiovascular risks. But in the risk calculator, there wasn't a direct correlation. But I mean, patients sitting in front of me, I will reclassify according to what they look like, how they live, and what are the variables that I think are important. But using the guide from the risk calculator, because the risk calculator is the absolute evidence-based tool. And Jenny,
can I just add something to that, which is there are risk calculators that include BMI, but if those risk calculators take out the lipid measures. And that's because they're so kind of closely related that if you put one into the risk calculator, you've essentially accounted for most of the risk. So
yeah, that's quite right. Certainly in the data that this was the large cohort this was derived from. It's not that BMI isn't associated with, and we know BMI is not a great measure of obesity, but it's not that it isn't associated with cardiovascular risk. It is, but you can account for it with all the other variables that are already in the equation. So you don't have to add that on top of it. It doesn't mean you ignore it, doesn't mean you don't manage it. It just means it's not going to improve your classification. Another one we just dealt with, I think Jenny dealt with it briefly, is what about PBS criteria for statin therapy? Can we prescribe for intermediate risk patients? Jenny, do you?
yes.
yes, so this has been something that has worried people, but in 2017, the PDAC changed the prescribing criteria so that now it just says a restricted benefit, and it's basically in accordance with the absolute risk guidelines. So the two things now agree.
Okay, thank you. I've got a really important one. Why is preeclampsia not included in the calculator, and what should we do for this group of patients? It is included in the calculator, not in the calculator itself, but it is included in the guideline. It's something that warrants very close attention. It is also one of those things that I mentioned before where not everything's in the calculator, and some things are not there because we just don't have sufficient data to be able to put a number on it. Doesn't mean it's not important, doesn't mean we shouldn't be considering it. But Garry, do you want to talk to?
I think this is a really important question. I mean, it's about current cardiovascular risk, and we know that people with preeclampsia, if they don't have current cardiovascular or elevated blood pressure, you should be repeating the cardiovascular risk assessment on appropriate intervals. I mean, if they're at intermediate or high risk, I mean, high risk, of course, you don't need to repeat the calculator because they're already high risk. But if they're intermediate risk, maybe we normally say 2 years, but you might, on a clinical judgment, bring it closer because you're thinking that person or that woman is at higher risk. It's like people with pre-diabetes. I mean, we've included diabetes as the calculator, but we know people with pre-diabetes have high risk. So, we can use the interval assessment appropriate to that person. There are judgments on general guidelines every 2 years, but maybe a little bit more often in those people on that between maybe high, intermediate, on the higher of the intermediate risk calculator. But it's current blood pressure is really what's most relevant in those women with preeclampsia.
So Tony, we're seeing more and more hypoglycemia during pregnancy. What would you comment on what that might mean for future management of the individual?
Yes, thanks, Garry. I mean, those women are obviously at increased risk of developing diabetes with about a 50% risk in the next 10 years. And the recommendations are that they therefore have regular screening for diabetes postpartum. And obviously, as part of that screening, you'll be looking at blood pressure as well, and general cardiovascular risk. And then hopefully you'll be picking up that risk and putting it into the calculator. So I think you'll be have a higher awareness. You'll be doing the relevant screening to detect the condition that may develop that's putting them at risk of high cardiovascular disease. So I think that would be the approach, and that again is sort of discussed in the guidelines as well.
Thank you. Anyone else want to comment?
Just to remind you that the RACGP Red Book, which is the preventive handbook, is incorporating this new evidence into their publication, which will be out early in the year. So for those people who are concerned about some of the nuances of previous RACGP advice, we've taken the advice of the Heart Foundation and they'll be definitely incorporated. So watch this space.
Thank you. I see on the chat line, is it still recommended to use clinic blood pressure instead of home and ambulatory blood pressure? I'm happy to deal with that one, but unless anybody else wants to jump in.
I think the evidence is that in-clinic blood pressure is what you use in the calculator. Try to do an average of a couple of blood pressure measurements, or you can, get the average from home measurements. But Gary, what do you think? I'll leave it over to you.
Well, I certainly think that there's an important role for home and ambulatory blood pressure readings in managing people with hypertension, and in better discrimination. But these data are based on clinic readings, the average of the last 2 seated in clinic blood pressure measurements, and that's what the coefficients in the predictive equation came from. If you've got home or ambulatory blood pressure readings, there are tables online that you can look up to try and see what the in-clinic equivalent would be. And that would deal with a number of questions actually that we mightn't be able to deal with individually. A lot of the definitions are in the question mark beside the question in the actual calculator. If you want to know what we mean by A, B or C, that's where you look. And because they were the definitions used in the derivation of the equation. Got a question: should someone with a high score have a stress echo or myocardial perfusion scan? The answer is no. They are for people with angina, where you're looking for obstructive coronary disease, and not useful in the general population. There's a question about inflammatory conditions like rheumatoid arthritis. Any considerations to be given while you're calculating the cardiovascular risk?
I want to answer that because again, it goes back to how the calculator is derived. So some of these inflammatory conditions, in particular rheumatoid arthritis, SLE, some of these other conditions, which are very well recognised that they increase your risk of cardiovascular disease, they are not in the calculator. And one reason for that is because they only affect a very small proportion of people in the general population. It's hard to kind of include them in a calculator that's derived for, based on general data. Again, if you've got somebody who's got one of those kind of inflammatory conditions, it's known to increase CVD risk, then you probably should think about that in terms of increasing their risk category.
Yeah, it's a bit like our discussion about preeclampsia, isn't it?
Yes.
It's not yet clear from the evidence the extent to which the high risk associated with these things are due to things that are already variables we already have in the equation.
Yes. In fact, the evidence for RA and SLE is actually stronger than it is for preeclampsia and gestational diabetes, where, like, for example, gestational diabetes and preeclampsia tend to move into the type 2 diabetes and high blood pressure. RA and SLE don't. So, yeah.
Okay. I've got one for you, Tony, for people with impaired glucose tolerance or impaired fasting glucose, would you suggest clicking on the diabetes yes and then assuming a slightly lower risk than that calculated?
I think Gary sort of addressed this a little bit earlier. I think no, I don't think so. I think we should be increasing the interval of our assessing risk, and we should be doing regular testing for the development of diabetes in that cohort, and addressing the individual risk factors that are associated with it itself in terms of often their metabolic syndrome, potentially hypertension, dyslipidemia, that would then be incorporated in the calculator. So I don't think I would at this stage. I know that's a graduated risk, but it would be increasing the interval of screening and reassessing. That would be my approach.
Thank you. Got another question. What's the role of aspirin? Is it recommended for high risk?
That's a difficult thing, but no, unless you've got established cardiovascular disease. I think the risks have been shown in clinical trials to exceed the benefit unless you've got some secondary prevention, because you've already established that they need it, but just don't use it as a primary preventive tool.
Yes, that's certainly the Heart Foundation position, is that there's no evidence in primary prevention that aspirin has a positive cost benefit. Different, of course, in people who already have established diseases. At what age do we consider ceasing statins or not starting them? Does anybody have an upper age limit as far as prevention is concerned? I think we can say the same thing about blood pressure.
I think in primary care, I think this is an important thing to think about. We're currently, I'm part of a Monash trial called the STAR-E trial, looking at the use of statins in the elderly, and that hasn't been fully reported yet. So, the evidence in the particularly over 85-year-olds, I mean, I don't think the evidence is as clear as it should be, even over 75. But if a person's already got established high cardiovascular risk or existing disease, is there a benefit? I think this is how we practice clinical medicine. It's about an informed patient, having an informed discussion about what outcomes are we trying to achieve. If my father's 96, for instance, and would I feel that if he had a TIA that starting a statin at 96 will improve clinical outcomes? I'd discuss that with that person and with some care workers or their care services. It's like the same thing about aspirin, you see. So I think, what is the classification of the elderly? I think we need to be careful classifying people on age. I think it's about the presence of existing comorbidities or potential risks. And that's something that and also putting the patient first and having a clear discussion.
Thank you. Very sensible. And we're also, I should say, hoping that with new data coming from the New Zealand population, that we'll be able to extend the upper age group at which this calculator is valid and applicable. Another one probably for me: are coronary artery calcium scores accurate in older or younger patients? This is a really important question. Calcium gets deposited effectively with healing of atherosclerosis. It's not the first thing that happens when somebody develops atherosclerosis. And that's important in the young because they can have what's known as soft plaque without calcium. And soft plaque is particularly vulnerable to disruption and acute events. So there is a significant number of, if you go too young with your coronary artery calcium scores, false reassurance as far as a score of 0. At the other end of the age range, though, in older people, everybody gets calcium in their arteries, so it becomes less discriminatory in older people too. It's really in the middle ages that it's probably of most benefit. Got a question. Are there any lipid targets for primary prevention? The answer is not in this guideline, but would you like to explain why? Perhaps one for Jenny and Gary, I think. I think
lipid targets, second prevention, I think they're getting clearer, and the international guidelines are certainly looking at and we're looking at LDL, and I'm not an expert, Gary, so please, I'm only a general practitioner, but an LDL target of less than 1.4 would be most appropriate for those people with high established cardiovascular disease. In primary prevention, though, we're currently looking at that in the diabetes handbook, for instance, and diabetes are another group that have a slightly elevated risk, but certainly LDL targets less than 1.8 of the current, in our current guidelines, or less than 2, but maybe lower than 1.8. But Jenny, what do you think?
We looked at this, I was on PBAC for a while, and we looked at this while I was on PBAC, and there wasn't a lot of evidence that, especially in primary prevention, that having a target improved outcomes. I don't know if there's been any update on that evidence, but I think you could put a lot of effort into trying to chase targets. The big thing is getting the person on the statin that needs it. That's by far the most important thing.
And maintaining them on it.
Yes, keeping them on it.
The thing is, does the person take it and stay on it?
Yeah.
I think that's right. And if you look at the secondary prevention guidelines around the world, some of them just recommend the maximum tolerated dose of statin full stop, and others do recommend targets. And it was a matter of considerable discussion amongst our various expert advisors. What else have we got here? We've got so many great questions. When would you consider a screening CTCA, that's a CT coronary angiogram, is this reasonable to do in intermediate or high risk patients? I think that relates, well, firstly, I'd certainly do that in somebody with angina, somebody with symptoms. It has value and obviates the need for an invasive coronary artery study. I don't think it's reasonable to do in intermediate or high risk patients who are stable, because the evidence, as some of you would have seen some news yesterday, that's in stable coronary disease, is that lifestyle and best practice medical therapy has just as good an outcome as any intervention. So as long as the patient's stable, I wouldn't be considering CTCA unless there was some other reason. Well, we're really getting down to some details now. Perhaps Tony could help with this. How do you choose the best type of statin for the patient? When do you include the second medication such as ezetimibe?
Well, I think if you've had an event, you're trying to maximise statin doses, and that would be the recommendation. And I guess that's then where I personally would be chasing a target of less than 1.4. So to achieve that, it's a statin, then adding in the ezetimibe. And then, of course, if you're not achieving that, then you've got the option of PCSK9 inhibitors now, PPS in bursts for those patients. So that's where I think sort of the move in the field has sort of, with these newer agents, has allowed us to have sort of a target to target in primary prevention. But in secondary prevention, but in primary prevention, it's unclear, isn't it? And I think just going for that intermediate dose is probably reasonable with a statin. If they're not able to tolerate it, then consider adding in the ezetimibe on top of that. That would be my approach, Garry.
Yeah. Look, what about? Well, we would generally recommend the more potent statins. That's the atorvastatin or rosuvastatin. But what about, while we've got you, Tony, what about the reports, which have been around for a while actually, of a slight increase in risk of diabetes in people on statins? How does that compare with the benefits of statins in people?
I think the benefits outweigh the risks of that small increased risk of developing diabetes personally. So, you have that discussion with the patient, the risk is small, but the benefits of the statin outweigh that small risk of diabetes.
Thank you. A question that often comes up, people like to measure CRP. Why isn't that in the equation or in the other factors for consideration? Jenny, do you want to, or Garry, do you want to?
So that's been looked at a number of times, both here in the US and by the US PTF and various places, and it doesn't improve the C statistic hardly at all. So basically, it doesn't improve your discrimination.
As you eloquently said before, Garry, all the parameters that CRP probably influences are already in the calculator. So adding that in doesn't improve discrimination at all.
Yes, and look, it's one of those things where there are fierce advocates and very good at promoting a particular line, but these data these are evidence-based guidelines, and we're not saying they couldn't be important. We're just saying we don't have the evidence to be able to include them. I think we probably will wrap it up at that point. We've covered a lot of your questions. I'm sorry we've not covered everything. This will be available online, this discussion, if you want to revisit. As Garry mentioned, there are a whole lot of terrific resources available to you, not just the calculator itself, which has the whole guideline, as well as I said, the various help buttons that you can press against any of the questions in the calculation at www.cvdcheck.org.au. There's a summary infographic which really condenses it all to a one-page, well, 2 pages, front back, and there's a consumer fact sheet that you can access through the Heart Foundation, as well as a promotion pack with background and social media assets. So I hope with all that you'll be well armed to really be able to make the most value out of what we think is a wonderful new tool for not just for us, but for the Australian community. I'd like to end by thanking our panelists, who I think have done a wonderful job in making even these very complex issues very, very clear. And also special thanks to our Heart Foundation team led by Natalie Raffel, who really not only delivered tonight, but delivered the whole guideline in such a comprehensive and I think hugely intelligent way. So I can't underestimate how much work it has taken to get us to this point, but I think we're in a very good position to implement this guideline in primary care throughout Australia. So thank you all very much, and we'll see you at our next webinar in the next month or so.